السلام عليكم ورحمة الله. الله يعطيكم العافية جميعا. مشت ولا مشتش؟ Yes. Our case is a 43 years old male patient, non-risk factor only smoking, presented to the emergency room complaining of typical chest pain. ECG and labs was okay, and the echo was unremarkable. So to come to the cath lab, this is our first shot. And this is the cranial view. If you see a post diagonal, we have a tight lesion on the LED. This is another views. And also we have an AV fistula. And we decided to, and this is the right coronary artery also. We have the same also fistulas also on the right coronary arteries. So we decide to go to intervention, intervene to the LED. This is a GL 3.55 French because we have some radial spans, so we took a 5 French guiding catheter. And we put our stent was 2.75 by 28 millimeter stent. And this is after stenting. And we go for post dilatation for this stent by NC balloon 3 by 15 millimeter NC balloon. And oops, this is what happened after post dilatation of this stent. This is type 3 perforation, which is, the Ellis classification type 1, type 2, type 3, or the modified one, which is in the cavity become type 4. So what we do in this time, we do prolonged balloon inflation. I retain by a balloon, and we do prolonged balloon inflation. Notably, we don't have, sorry for that, we don't have a cover stent is unavailable in our cath lab at that time. So we asked the company to come to our cath lab. And after prolonged balloon dilatation, this is the perforation is still present. Till now, cover stent not available on the way. So what I did, I put another femoral, another axis. I put a femoral axis, a Sheridan guide and wire from femoral axis because my one was a 5 French from the radial. And after that, I put an ordinary stent insertion from another stent through another guide. The femoral one, I put another stent. And this is our new guide, and this is post-stenting. In spite of this, we have some leak, still is present. So we return to do prolonged re-inflation of the balloon for prolonged balloon inflation. And this is after prolonged inflation, still perforation is present. If you this one, the perforation is still present. And the patient remained hemodynamically stable. And thanks for God, the cover stent is coming. So we put our cover stent. This is my first cover stent. And inflate the cover stent, post-inflation of the cover stent. In spite of putting the cover stent, we have some, if you are seeing this, there's some width in this area. If you see it. So I do edge of the stent post-dilatation, still some width. So I do cover stent edge post-dilatation. And after that, it's okay. And this is the post dilatation of the edge of the stent. Everything is okay. But after 10 minutes, this is what stent we use it is the Bentley stent. Bentley stent is from the B graft. It can be used can be inserted in 5 French catheter. It is not like the graft master, which you need 6 or 7 French guiding catheter. But after 10 minutes, repeat angiogram. Do you see anything? Look at this is after 10 minutes. There's a small width if you can see it on this side. Yes, at the edge of the stent. Wait a minute. So this is our second cover stent. We put a second cover stent at the edge of the first stent, and everything went okay. Hemodynamically still, the patient is stable, hemodynamically stable. And this is the final shots, everything. So this is the echo in the cath lab. We have moderate to large pericardial effusion, but no tamponading. So patient remains hemodynamically stable and echo repeated after 2 hours, also no change. I want to have one question. What's your opinions? Do you aspirate this pericardial effusion or not? How many will aspirate? Only 2 from only 5. And all the others, only 6. The other will not aspirate. That's good. Okay. So I kept him in medical treatment, no aspiration done, dual antibreaker transferred to the CCU. This is the echo on the second day, and the echo on the third day was lesser than before, myocardial effusion, and after that, I transferred him to the floor, remains stable, and discharged home after 1 day. I add colchicine empirically, really, because I think he might have developed iatrogenic Dressler syndrome like this. After 1 week, everything is stable. This is our echo. Almost the myocardial effusion is less than before, if you see only on the posterior part, but is less than before. Second visit was after 1 month from the procedure. Patient developed shortness of breath and chest pain of 2 days duration, examination stable, vital signs, ECG, no changes. This is what we see on the second, after 1 month of the procedure. There is a large pericardial infusion. I want to ask you, who will aspirate this fusion? How many now? Yeah, then 1/3. So let's count who will aspirate. Do you anybody will recast the patients?
Do you have subcostal view?
By this is, I don't know. But the patient, what I did, I put the patient on the prednisolone therapy with the colchicine. Patient relieved his symptoms after the first dose of the prednisolone therapy, and this is the echo after 1 week of prednisolone therapy. And echo after 3 weeks, no pericardial effusion. Coronary perforation is common, especially in CTO operation. What I want to make your message, don't hesitate to ask for support of other PCI operator or cardiac surgeon as needed. And this is, we will not talk about how you can do it. I think one of the important things is serial echocardiogram should be performed to assess for hemopericardium and tamponade. And also full or partial reversal of heparin can be done, but after the gear are removed, protamine dose of 50 to 50 milligram has been recommended, but I didn't do this, and you do this after removing all things. Thank you very much.
Thank you.